Hello guys and welcome back to my channel. My name is Tommy. I'm a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize the classes I have at the university, and then I explain and teach you the best and most valuable information you need to know. Today we're going to continue the series of physiopathology, and we're going to take a look at the heart, the blood and the circulation of the whole body. So let's begin. Cardiac insufficiency first. The cardiac output, you must know, it is the blood volume pumped per minute. So the amount of liquid, the amount of blood that the heart pumps. Normally it is about 70 milliliters per minute. So the cardiac output, we can say it is the pre-charge, which is the amount of blood that gets inside the heart before the contraction. The contractility, the ability of the heart to contract, multiplied by the heart rate and divided by the post-charge. The post-charge is the amount of liquid after being pumped. This is before being pumped and this is after. So the cardiac insufficiency is when the cardiac output is lower than the blood supply needed by the tissues. Causes of this cardiac insufficiency: ischemic cardiopathy and arterial hypertension. Symptoms depending if before or after the congestion. So basically the symptoms depend on the congestion, where it is located, if it is before or after the heart, for example. If it is right after, it will affect the post-charge. If it is before, it will affect the pre-charge. Compensation mechanisms, we have intrinsic ones, the cardiac hypertrophy or dilation. Basically, what it says here is that the heart tries to compensate via hypertrophy, so increasing the contractility, or via dilation, which indeed is increasing the pre-charge. Because if you increase the post-charge, you're going to decrease the cardiac output. Extrinsic mechanisms, sympathetic nervous system, for example, the catecholamines will produce tachycardia, and then tachycardia will affect the heart rate, and also the renin, angiotensin, aldosterone will increase the pre-charge and therefore the cardiac output, as well as the ADH, the antidiuretic hormone, and the vasopressin. Here you have to know that these things, even though they don't seem to be correlated with the cardiac insufficiency, they are relevant because the body is not separated, it is all integrated in one thing. The dyspnea, because pnea is air, dyspnea is when you have not enough air. Autopnea is the dyspnea when lying down, and the jugular hypertension is when the blood cannot enter the heart. Then let's take a look at coronary heart disease. So the heart is three layers: the endocardium, the myocardium, which is the muscle, and the pericardium. And you have to know that the sinuses of Valsalva are very important because they are the origin of the coronary artery. This is the artery that goes to the heart. Yes, because the heart needs blood to be able to contract, because the myocardium is indeed a muscle. The coronary circulation, well, it is phasic. Phasic flow, contrary to the normal circulation, of 80 to 100 milliliters of blood per 100 grams of myocardium per minute. And here we have to take a look at the dominance. The dominance depends on the posterior intraventricular artery, if it is derived from the left or right coronary artery. Right should be the majority, 75-80% of right dominance of the coronary circulation. Therefore, having this in mind, the coronary insufficiency is when the flow is unable to satisfy the myocardial needs, as well as the cardiac insufficiency, but here to the coronary one. So this happens when there is a low coronary reserve, higher requirements of blood, for example, low quantity of blood, low oxygen, low flow, higher demand of oxygen, higher ventricular strain, and higher heart rate will require more blood to the heart. The most common problem is due to atheromatosis, which is the atheroma plaque. And this, what it does is to change the pressure. The causes are dyslipidemias, cholesterol, obesity, diabetes mellitus, smoking, and also the arterial hypertension. The consequences are myocardial necrosis. Necrosis is the death of the cell, and therefore myocardial infarction. Biochemical consequences are higher production of lactic acid, higher protons, which will create an acidity and therefore pain. And in the clinical, there is high troponin. Also, electricity has to do with it because electrolytes, arrhythmias, and the stress, all taking part with sympathetic nervous system, are indeed the biochemical consequences of coronary insufficiency. And then we have the mechanical, which can be either an acute ischemia or a chronic ischemia. The acute one, partial necrosis, the chronic one, myocardial hibernation. Then we have the coronary insufficiency syndromes. The silent ischemia, when we have no symptoms. The chronic coronary syndromes, stable angina, and an atheroma plaque that causes pain when doing exercise. Number 3, we have acute coronary syndromes, unstable angina, and there is perpetual pain. We can have here a transmural Q and a non-Q acute myocardial infarction, and also sudden death, which is a ventricular fibrillation. And here comes the use of defibrillators. Now it's time to take a look at high blood pressure. Chronic elevation of arterial blood pressure. This is what it is. It affects the heart, the brain, the kidney, and other diseases, because indeed the blood goes to the whole body. The main cause is atherosclerosis. Blood pressure is dynamic and changes a lot. The differences between the clinic and at home are very high. So we have to take good measures to check if there are masked hypertensives. We have to do the procedures of taking the blood pressure of an individual both in the clinic and at home. Physiopathology, well, pressure exerted by the blood on the vessels. Regulation mechanisms, rapid control system via baroreceptors, chemoreceptors, and ischemic response, via intermediate control system using the renin-angiotensin-aldosterone system, and also we have the slow control system, which is part of this renin-angiotensin-aldosterone as well. Measures: we have to avoid anxiety, constipation, pain, caffeine, smoking, urination. It has to be a comfortable and quiet environment. Comfortable posture, the arm must be at the heart level, the feet touching the ground without crossing. We have to facilitate the blood flow. And the cuff must be according to the arm circumference. This, again, must be done in the clinic. Sometimes we do it at the start and at the end of the session, and at the home as well. High blood pressure causes. Well, this is an epiphenomenon, which means that it's also correlated with other diseases, and it has to do with autosclerosis, which is the hardening of the arteries, but also via the coarctation of the aorta. This will increase the systolic and diastolic pressures. The causes, the first ones are idiopathic or essential, the 90% of them, and the causes are unknown. The secondary ones are because of high flow or higher resistance, and it's only the 10% due to stress, alcohol, drugs, and smoking. The consequences of hypertension, arterial thrombosis, stroke, angina pectoris, and myocardial infarction. The treatment, it depends on the age. What we can do is to change the lifestyle, a balanced diet, a lower sodium diet, physical exercise, and healthy habits. And then last but not least, we talk about shock, which is the peripheral circulatory insufficiency. It is a general hypoperfusion, acute severe decrease in blood flow, so the blood stops to flow. This is a medical emergency because it can be life-threatening. During this state, we do not feed the individual, neither by mouth, nor by nasogastric tube, nor parenterally. It is an unstable individual. Pressure rises and falls, and there is low nutritional security. So what do? We stop the shock and then we feed. Classification of shock. Hypovolemic is when we have low effective circulation volume, therefore low cardiac output, and this will create peripheral hypoperfusion. This happens with, for example, an acute hemorrhage, dehydration, and the third space. This is, for example, when the pericardium gets filled with a liquid, and therefore it will impede the myocardium to contract properly. Then we have distributive shock, which is the dilatation of blood vessels. There is a blood stagnation and therefore hypoperfusion. This happens with sepsis, anaphylaxis, endocrinologic toxics, and neurogenic as well. Extracardiac obstructive is when there is an obstruction. There is a retrograde accumulation, no blood outflow from the heart, and therefore hypoperfusion. Imagine that there is an obstruction and the blood continues to flow until that obstruction. Then it will continue to build up and there is an accumulation, a retrograde accumulation. And this happens because of pulmonary thromboembolism. So when the blood gets accumulated in the lungs, or pneumothorax. When there is air in the pleural cavity, therefore the lung cannot really expand to its full potential, but the other one can, and this will create a movement of the heart towards the center. This will pinch the aorta artery, creating an obstruction there and impeding the blood flow. Then there is the cardiogenic, which is a drastic decrease in cardiac output, and therefore we have a peripheral hypoperfusion. This happens with cardiomyopathies and as well as mechanical, for example, the valvular insufficiency. Here we're talking about the valve between the auricula and ventriculum. And also because of arrhythmias, we can have a decrease in the cardiac output. Microcirculation consequences, well, metabolic. We have low ATP, high amount of lactate, and therefore acidosis. Inflammation will increase the capillary permeability. Then we also have pre- and post-capillary sphincter disturbances, slow circulation of the blood in the body, peripheral microthrombosis as well, because the blood gets stuck in the peripheral of the body. Compensatory mechanisms, hyperventilation. Then there is a mucosal necrosis in the gastrointestinal tract, therefore there is a bacterial translocation. The bacteria of the gut can get inside the organism, which is something we do not want. The liver, well, the centrolobular necrosis. At the kidney level, well, we have lower circulation, therefore more urea, higher urea levels. And in the heart, we have tachycardia, dilatation, higher contractility, and that will equal depression. Metabolic disorders, we have hyperglycemia and increased anaerobic metabolism. As we said here, this is indeed anaerobic. The renin-angiotensin-aldosterone system will also act, as well as the ADH, the antidiuretic hormone, and the catecholamines such as the noradrenaline mainly. They are all involved in the shock, because they are all involved in the blood circulation indeed. Per se, the shock has several phases and mechanisms. And the main treatment to the shock is to restore the peripheral perfusion, and only then you can feed. Stop the shock and then feed. That's it. This is it for this video. I hope you liked it and you learned something new today with me. You can find this diagram by clicking in the first link in the description down below and study it very well. It's yours. Remember to like this video, share it, and subscribe to the channel for more content like this. Thank you so much for watching, and we'll see you in the next one. Ciao! Hope you enjoyed.